Hyponatremia, or low sodium levels, can result from the loss of sodium through fluids like diarrhea, vomiting, or drainage. It can also be caused by overhydration, such as in the syndrome of inappropriate antidiuretic hormone, SIDH, or excessive intake of hypotonic fluids. Renal failure or adrenal insufficiency may also lead to hyponatremia. Symptoms include neurological effects such as irritability, confusion, headaches, and in severe cases, seizures or coma. Cellular swelling due to fluid shifts is a hallmark of this condition. Management involves fluid restriction if caused by water excess, replacing sodium using isotonic or hypertonic saline for severe cases, and frequent monitoring of serum sodium levels. Rapid correction must be avoided to prevent complications like brain damage. Hyperkalemia, or high potassium levels, can occur due to impaired potassium excretion caused by kidney disease or medications like ACE inhibitors. It may also result from a shift of potassium out of cells due to acidosis or tissue destruction, or from excessive dietary intake or IV potassium administration. Symptoms include ECG changes such as peaked T waves and widened QRS complexes, as well as muscle weakness, cramps, or paralysis. Severe cases may lead to life-threatening cardiac dysrhythmias. Management includes administering diuretics or medications like insulin to shift potassium into cells, using IV calcium gluconate for heart stabilization, and limiting dietary potassium while addressing the underlying cause. Hypokalemia, or low potassium levels, is often caused by the loss of potassium through gastrointestinal fluids, diuretics, or inadequate dietary intake. Potassium shifts into cells can also occur due to conditions like alkalosis or insulin use. Symptoms include muscle weakness, cramps, fatigue, and ECG changes such as flattened T waves and ST depression. Severe cases may lead to respiratory failure or cardiac arrest. Treatment involves potassium replacement through oral or IV supplements, ensuring proper dilution, and monitoring ECG and potassium levels to avoid overcorrection. In managing these electrolyte imbalances, it is critical to regularly monitor lab values such as sodium and potassium levels, assess cardiac and neurological function frequently, and educate patients on dietary restrictions and medication compliance. Caution with IV therapy is necessary to prevent rapid shifts in electrolytes. Preventing complications like seizures and hyponatremia or cardiac arrest and hyperkalemia is essential. Addressing root causes ensures long-term stability. Phosphate imbalances include hyperphosphatemia and hypophosphatemia. Hyperphosphatemia, or high phosphate levels, commonly results from kidney failure, where phosphate excretion is impaired, excessive intake from supplements or medications, or cellular destruction in conditions such as rhabdomyolysis or tumor lysis syndrome. Hypoparathyroidism can also decrease phosphate excretion. Symptoms include muscle cramps, tetany, and tingling sensations due to low calcium levels caused by elevated phosphate. Long-term complications may include calcifications in soft tissues such as joints, kidneys, or arteries. Management involves limiting dietary phosphate intake, using phosphate binders like calcium carbonate, or dialysis in severe cases. Hypophosphatemia, or low phosphate levels, may occur due to chronic malnutrition, alcoholism, antacids containing magnesium or aluminum, or conditions like diabetic ketoacidosis. Symptoms include muscle weakness, fatigue, and in severe cases, confusion, respiratory failure, or cardiomyopathy. Treatment involves increasing dietary phosphate intake or using supplements, with IV administration reserved for severe cases and done cautiously. Magnesium imbalances include hypermagnesemia and hypomagnesemia. Hypermagnesemia, or high magnesium levels, often results from kidney failure, where magnesium excretion is reduced, or excessive intake of magnesium containing antacids or laxatives. Symptoms include drowsiness, lethargy, and muscle weakness, with severe cases potentially leading to respiratory arrest or cardiac dysrhythmias. Treatment includes discontinuing magnesium-containing medications, administering calcium gluconate to counteract effects on the heart, and dialysis for kidney failure patients. Hypomagnesemia, or low magnesium levels, can result from poor dietary intake, malabsorption, chronic diarrhea, alcoholism, or diuretics that increase magnesium loss. Symptoms include muscle cramps, tremors, cardiac arrhythmias, confusion, and seizures. Treatment involves oral magnesium supplements for mild cases or intravenous magnesium sulfate for severe deficiency, with close monitoring to prevent overcorrection. Dialysis is a life-saving procedure for patients with kidney failure or certain critical conditions. It removes waste products, excess fluids, and toxins from the blood. The two primary types of dialysis are peritoneal dialysis PD and hemodialysis HD, with continuous renal replacement therapy CRRT reserved for critically ill patients. Dialysis mimics kidney function by using a semi-permeable membrane to remove waste fluid and electrolytes. Access for dialysis includes vascular entry points for hemodialysis, or a catheter in the peritoneal cavity for PD. Dialysis cycles vary depending on patient needs and include regular treatments. In peritoneal dialysis PD, a catheter is placed in the abdominal wall to allow dialysate, a special solution. to flow into the peritoneal cavity. The peritoneal membrane acts as a filter, drawing waste and toxins into the solution, which is later drained. Dialysis solutions typically contain glucose to facilitate removal. PD cycles include filling, dwelling, and draining phases. It can be done manually several times daily, as in continuous ambulatory peritoneal dialysis CAPD or the machine overnight, as in automated peritoneal dialysis APD. Complications of PD include exit site infections, peritonitis, hernias, low back problems, bleeding, pulmonary complications, and protein loss, which can lead to malnutrition. In hemodialysis HD, blood is withdrawn through a vascular access point, passed through a dialyzer artificial kidney, and returned to the body. Access points include arteriovenous fistulas, arteriovenous grafts, or temporary catheters. Complications of HD include hypotension, muscle cramps, blood loss, infections, and air embolism. Continuous renal replacement therapy, CRR, is used for critically ill patients who cannot tolerate traditional dialysis. It involves continuous blood filtration over 24 hours to prevent sudden changes in blood pressure or heart function. Access is typically through central venous catheters. Nursing care includes monitoring access sites for infection or complications, educating patients on hygiene, ensuring proper dietary management, and closely monitoring fluid balance and signs of complications such as peritonitis, bleeding, or respiratory distress. These comprehensive approaches ensure patient safety and effective management of dialysis and electrolyte imbalances.